Hello, I'm Jason Rizzo. I'm a Mohs surgeon and dermatologist. I practice in Southwest Florida at the Woodruff Institute in Bonita Springs and Naples. I'm here to talk to you today about the utility of 31 GEP testing for prognosis in cutaneous melanoma. So the first question is, how can the 31 GEP test inform routine imaging guidance for the purpose of detecting melanoma recurrence earlier? And the answer for this comes from a publication from Dillon et al. It's a study done at several prominent NCI cancer institutes at Northwestern, Cleveland Clinic, and OHSU. And so we looked at the use of prognostic GEP testing, which can identify patients that are at higher risk for melanoma recurrence and/or metastasis, and finding those who are at higher risk by GEP testing and enrolling them in a standardized imaging protocol for surveillance to help detect recurrence earlier. Now, it's important to note that in stage one and stage two melanomas, there is no standard of care for routine imaging. It's kind of at the discretion of the treating physician. However, this study did show that those patients who were flagged as being at higher risk for recurrence or metastasis that were subsequently enrolled in a routine imaging protocol, whether that's ultrasound, CT, or PET every 3 to 6 months, those patients were able to detect recurrence earlier at lower tumoral burden and actually had better clinical outcomes. So that speaks to the ability of this test to identify those patients who would benefit from a higher level of care. And that's really what GP testing is all about. It's about finding those patients, treating them based on the biology of their tumor in terms of the risk of these tumors biologically recurring or spreading, which sometimes is captured by the standard clinical and pathological staging, but sometimes that's missed. So there are patients with stage one and two disease that have recurrences and metastasis. So we can find those few patients and devote more resources to them. It can make a clinically meaningful difference. So the second question is, can you discuss the prognostic utility of 31 GEP testing through its consistent risk stratification across patients with melanoma? So the answer to this comes from a meta-analysis that was published in 2024 by Ryan Durgam and colleagues in the journal Cancers. And what they did is they looked at previously published literature, studies that met a certain criteria in terms of quality and bias. 13 studies were selected for this meta-analysis, including 14,760 patients. And this is actually the highest level of evidence you can have in terms of the literature. We're summarizing all forms of data, and we're looking at how consistent and reproducible a signal is in terms of, in this case, the ability of the GEP test to stratify the risk of recurrence-free survival for melanoma and metastatic-free survival for melanoma. And what we saw is across these 13 studies, the test is reliably and reproducibly able to predict and identify those patients that are at higher risk of metastasis and a recurrence from melanoma. It's powerful as a meta-analysis because it's looking across multiple studies, multiple formats, multiple patient populations, and that really speaks to how robust of a signal this test can give you. And as a clinician, you want to use a test that's reproducible and robust, meaning that regardless of the patient population or the format of the study, it's giving you a reliable and strong signal. So again, a meta-analysis is the supreme level of data we can get, and it speaks to the ability of this test to identify those patients based on their tumor biology that are at higher risk for recurrence or metastasis.